Welcome to Red, White, and Blue. I'm Gary Polland, and this week's co-host is Dallas Jones. Dallas, welcome. You're looking good. Our topic this week is the Texas healthcare system, which is a loose statement because I'm not sure we have a healthcare system. We're going to explore how healthcare works in Texas today and maybe some things we can do to make it work better. And we have two guests to do that. First, Dr. Umair Shaw, who is the Executive Director of Harris County Public Health, which means he is responsible for almost all of the health care that we're talking about for people in Harris County, lots of them. And secondly, David Balat, who's Director of Right on Healthcare from the Texas Public Policy Foundation, a great think tank in Austin. So, Dallas, here we are. How do you get your health care?
I'm insured, thankfully.
And what does it cost? Not to pry, but what do you pay a month?
Well, you're prying, Gary, but it's private insurance, and
expensive.
For me, my wife, and my 5-year-old daughter, we pay about $1,800 a month for insurance.
So that's expensive.
Absolutely.
Okay. Yeah, and I will to confess, I'm on Medicare. I know you don't believe I'm that old, but I am, and I pay I think about $1,000 a month on Medicare. So that's because I actually am still working and making a living. So that's kind of full disclosure on our experience with the medical care system. Let's start with you, Dr. Shaw. Harris County Medical Care healthcare system is really a significant healthcare provider. How many do we provide?
So
how many people we serve?
Yeah, so let me start off by saying thanks for having me, and I just wanted to say that there are a couple things that we need to remember is that it's a health system, and there is a public health system and really population health, and what we need to remember is beyond healthcare delivery, and then there's the healthcare delivery system, and so we have 4.7 million people in Harris County, and so you really essentially have to think about all of us as consumers and patients, and we have to really be thinking about the needs of the entirety of the population.
Well, why don't you tell us, to step back, Harris County Public Health, tell our viewers what that system entails, because they probably don't know.
So Harris County Public Health is the health department. We're the county health department, and we're really very much about remembering that it's about investing in health and not health care. And so we oftentimes get that confused in America, right? We talk about health care, we talk about healthcare delivery. I'm a physician, see patients, and so as a doc, I am very interested and very much invested in the individual care of that patient. But in public health, we're really concerned about the community's health, and we see the community as our patient. And so we're really interested in how do we invest in health. And this means that there are oftentimes programs that are not just in health care, but social programs, housing, transportation, education, jobs, food deserts. These are places where we need to invest really to ensure that the healthy choice is the default choice.
I love that. I love that because I've done a lot of work around food deserts, and I'm not sure that people understand the interconnection between your communities and all of the things that you mentioned, and preventative care versus, you're sick and where do I go? Right. Here's my question for you and for our viewers. Who can go to Harris Health?
So Harris County Public Health, we will see everyone who's a Harris County resident in our clinical programs and activities. We also have our partner agency, which is Harris Health System, which is really about the population and the healthcare delivery to the population. People who are not don't have other means to see to see a doctor, to see a provider, and so various clinics that Harris Health has set up and eligibility criteria in order to be able to see those patients.
Can I pause you there?
Yeah.
I'm sick. I'm uninsured. I don't have Medicare like Gary.
I have to pay for it.
Right. That's the point, right? And so we started and framed this with like numbers, right? Fortunately, Gary is paying about $800 less than I am, but for those that are paying nothing, can I go?
So the reality is that we're all paying something, and it's that the care, the system, or lack thereof, if you want to go with what Gary was saying, is that at the end of the day, we have 1 million people in Harris County who do not have health insurance.
Indeed.
And so where do they go for care? They go to emergency departments. They go to urgent care centers. They go to chaotic settings that are not interconnected. They go to places where at the end of the day, they're not getting comprehensive primary care, comprehensive patient care, because they don't have the mechanism to pay for that care. And that's the challenge.
If I could jump in there,
Yeah.
you know, not only the uninsured having that as an option, the insured are as well. If you look at Medicaid, if you look at private insurance under the ACA, if you look at the individual market, the deductibles are so high that people are functionally uninsured. If they don't have the money to go to the doctor or to take their sick child with 104 fever to their urgent care, what do? They go to the ER, because it's their last ditch resort. And they know that the ER will see them.
Ultimately. But you may wait a few hours.
And you may be punished financially after the fact.
But that's the part, right?
Yeah.
So you also end up with a huge bill. The ER is one of the worst places you can go.
It really is. Well, and not only for financial reasons. I was a hospital administrator for 20 years. If you're relatively healthy, do not go to the emergency room. You'll get sick, because that's where a lot of disease is going to be.
Wow.
The ER is a true emergency by definition. It's life or limb. If you're in danger of losing life or limb, the emergency room is the place to go.
That's an interesting, and I'm sorry, Gary, that's an interesting statement, because what you just said to people is, if you're sick, don't go to the ER because you might get sicker. I think there needs to be clarity about that.
Yeah, I think that.
Yeah, I'm going to let him answer that one, because I think, you know, at
Go
times,
to your clinics.
Well, we want people to go to the clinic.
That's where you should go.
But if access isn't there, so then people have no choice but to go to an urgent or an emergent care center. The issue, and I think this is where, you know, David is bringing it up, is that when we go to these centers, care is less organized. Not that the care there isn't organized, but it's not part of that system overall. It becomes more expensive.
Yes.
It becomes an individual who's further along in the disease process. Right. So at the end of the day, if I can prevent somebody from having or getting diabetes up front by screening and prevention, that is so much less expensive, so much better for the individual and the patient and the family than when they show up in the emergency department because they now have a crisis in diabetes. That's what we're trying to do.
That's what happened to me,
flip the narrative.
actually.
That's right.
It was crisis when I was diagnosed. But that's your question, because
we were talking before the
concerned.
show about healthcare. The system we currently have is not healthcare; it's sick care. Providers are reimbursed to be reactive. There is no methodology to keep people well. If we wanted to stay well, we'd have a relationship with a doctor, and that doesn't necessarily have to be expensive. It gets expensive because people wait and they delay, and they end up in the emergency rooms, just Umair had said earlier.
So if people come to your clinics, Dr. Shaw, do they have a regular relationship with a doctor, or at least a doctor who has access to their medical history and records? Is that how it works?
So yeah, I mean, so interconnected. So there are a couple things that go on, and you know, I think it's important to remember is that we do want to connect with the primary care provider or the overall health of that individual. The challenge becomes when there are freestanding emergency departments, there are urgent care clinics, there's chaotic care, there's episodic care, there's care where you go one time here, but then you turn around and go somewhere else near your work, then you go somewhere else where your child is near a daycare and you take your child to that urgent care center. How do you interconnect all that? That becomes a real challenge.
And so here's my concern. You all have said some very powerful things in different ways. One, you go to the ER, you're going to get sick. Maybe. Got that part. Clinics, urgent care, I have that part. Now, there's a dichotomy about this, because I've heard from a lot of people, and a lot of people feel that the urgent care clinics are inadequate, right? And the ER is too expensive. How do the people that are listening to us right now decipher between what the two of you are saying, which is different in terms of their care?
Yeah, I don't necessarily think that it's different. I think what we're both saying is that, and please correct me if I'm wrong, people need a relationship with a doctor.
Indeed.
An ongoing relationship. There's no need for, in most cases, you won't be treating the urgent care center or the emergency room like your regular doctor if you have a doctor that you see on a regular basis. That's first and foremost. Now, an urgent care can be adequate depending on what your needs are. But an emergency room is certainly adequate for and necessary regardless of you know, you don't think about how much it's going to cost if you have chest pain or if you have a loved one that has chest pain. And it may be anxiety or something you ate the night before. But you go just because you don't know. And you have to take care of you make the best decision for yourself and your family at that time.
And the other thing that I would just add to what David is saying is that he mentioned the word sick care. And that's really what we have. We have a sick care system. Is that when somebody gets sick, they present into the health care system. And we have to really start to change that narrative, where right now in America today, of the trillions of dollars that's spent on health, however you want to define that, health care, only 4%, 5% max is spent on prevention and public health. And the rest of it is spent on healthcare delivery, which becomes sick care. So what we really need to do is start to invest up front in all these activities that are going to really allow us to make sure that our population as a whole is healthier.
And if you want to look at percentages, the real travesty is that if you look at the $3.2 trillion that we spend as a nation on an annual basis, 40%, and that's conservative, goes to administrative middlemen that have no direct care with patients.
So, so the question then for you, David, would be this. How do we need to change the system so we eliminate the administrative overhead to the maximum extent possible and redirect the program, as both of you have indicated we need to do, where we create a really truly have a health system and not a sickness system?
Do we have enough time to fix health care?
We have 12 minutes.
Let me share with you. let me share with you what I do. You know, we talked about what you all do for your families and for yourselves. I am statistically, we talk about the uninsured statistics, I'm statistically uninsured because I don't have insurance. I use direct primary care where I pay a membership for a physician. For my family, I'll use my family of 4 as the marker. I pay $200 a month for a membership. It's 24/7 unlimited access to a doctor, and I call, video conference, or whatever the case may be. He gets me labs and radiology at a fraction of what I would use anywhere else. CTs at $250, labs for $30, whereas they would be hundreds, if not thousands upon thousands of dollars. I also, if something bad were to happen and needed to have hospitalization, I use a Christian sharing ministry. I personally use Samaritan. That's another $350 a month. So my monthly expense for healthcare coverage is about $550 for a family of 4.
Wow, that's
so.
amazing.
Is that sustainable? Can we do that for
How
everybody?
do I get on your plan?
Yeah,
We'll talk after.
you're going to save a lot of money.
I don't see why it isn't. But is it for everyone? Probably not. I think you have to look at what your family's needs are, and then you have to address that accordingly. And we need to look at all viable legal options that are there, and not just say that there is one option that is one size fits all for our community.
There's an elephant in the room, and there has always been. There are countries that have gotten this right. There are countries that have gotten this together, right? Some less developed than us. I was in Havana 3 weeks ago, where, frankly, everybody that lives in Cuba has access to health care. Explain to me why there, other places I've been, have gotten it right to where simply everyone has access to health care, and we simply don't. Now, I have what I believe the answer to be. I'd love to hear your thoughts.
Well, I think one thing, and David, you can certainly add to this.
Sure.
One thing I would say is that we in this country we've really put health insurance very much tied into jobs. And so it becomes an employee or employer-based, occupation-based insurance mechanism for the most part. And so what happens is if you have a great job, you've got great insurance, great. You don't have a great job, or your job cuts some of the benefits, you don't have as good insurance, now it starts to become a little bit murky. You don't have a job, now the insurance game becomes really hard. And then the other piece of this, which I think David was mentioning about the middleman, is that we have over time gotten to this point where the consumer, the patient, the individual, has gotten disconnected by how much it really truly costs for whatever it is that healthcare provider is asking that person to do. So if I say I need to do a knee replacement on you, but I don't tell you it's going to cost this much money because someone else, another third-party insurer, is going to pay for it, then there is no real ability for that individual to negotiate and or say right up front, Doc, I don't know if I want to get that individual, whatever decision is or that procedure is or that medication. because we've now divorced it. So we need to really bring a lot of these things up front, where the patient and the healthcare provider are together making decisions on what's best for that individual. But we have to remember that it's also about a population. At the end of the day, we have to be thinking about this as a community and not just thinking about that individual doctor relationship, but also how do we design the system so it works for everyone.
So David, how do we figure out what things cost? Since we know that the medical bills are just, I mean, from a legal standpoint, I think they engage in deceptive trade practices on a regular basis. Hospitals, doctors, I mean, 'cause there's no disclosure, nobody tells you nothing. You get the bill after.
We don't have a transparent system. It's very opaque. But I'd like to address Dallas's question. How come other countries have gotten it right? I would disagree with the premise. I don't think they've gotten it right. If you look at the national health system in England, there's a reason Mick Jagger's coming here for heart surgery. There's a reason why, we here just recently, we've heard that they've determined that cataract surgery is not something they're going to cover anymore. They're saying that they're so backed up on primary care visits that they may have to have group visits of 15 patients at a time. Now, is it true that they get access? Sure, but they don't tell you when. When I was in Costa Rica working with some folks, they have free health care. But one young lady was diagnosed with an ovarian cancer, and they said, well, we'll schedule you for surgery, you've been diagnosed, and we're going to get you an ultrasound. Well, ultrasound was scheduled for 12 months later. Well, when was the surgery going to be scheduled? Probably another year after that. That's a death sentence. So yes, she had access, but she was going to be in dire straits if she ever got there.
Yeah, but
that's the rationing part.
Yeah, and again, I don't
rationing
think
is an inevitability of socialized medicine.
I'm not here to debate your expertise, but what I'm saying is, for me, the point I made was about they have access. There are too many people and too many communities, and certainly the community I live in and others, where there's not access. Perfection? No. Access. And you hit that point.
Well, I think the flip side is, I think we have to remember is that we are spending an incredible amount, 17% of our GDP every year that's 19. On 19 now, on our healthcare system. And as we spend this amount, it's not that we're not spending, but when you look at the outcomes, we're falling behind when it comes to other countries in terms of what they're spending percentage-wise and what their outcomes are. So I think it's a complicated piece, but what we have to remember is at the end of the day, it's not just spending on it, it's spending it smarter. And I think that is the biggest challenge, is that, again, earlier we talked about how do we invest up front on that prevention, that health side, which is not what we're doing as a nation.
Well, the other thing I was going to throw out to you, if you look at examples in the free market system for medical care versus the controlled system, government, insurance companies, LASIK surgery. You go back when LASIK surgery started, it was really expensive. But competition, free market, advertising, full disclosure on what things cost, prices are down, 80% from what they started with? It's like buying big screen TVs. Every other part of the medical profession, I think, David, you mentioned insulin. How much has insulin gone up in the last 5 years?
In the last 20, it's gone up 10 to 15 times.
Well, and this is an old formula.
Hey, Gary, and let me tell you something I know, which is fascinating. It depends on which insulin you take.
That's true, too.
You can take the low dollar, you can take the high dollar. Depends on what pill. Yeah. Yes.
We're talking about a drug that's over 100 years old.
Yes.
100 years old.
My father takes insulin. When I first got diagnosed as a diabetic, my insulin was 3 times the cost of his. What was the difference? I could slip it in my pocket because it was a pen. It was emerging at the time.
Right.
Now, there's designer drugs that you can take in terms of pills, past metformin, Janumet, which insurance companies won't cover, but you'll pay $600 a month for.
That's right. That's right.
Why is it that there is a difference between the wealthy and the poor in terms of who gets the better medicine?
It's a travesty because, by and large, on that particular medicine that you mentioned, those are poorer communities. You see that statistically, it's going to be among Hispanics and blacks that have a higher prevalence of diabetes. Now, when it talks about transparency, let's talk about the cost of health care. Why is that? Why do we have the problems that we have? It's because government keeps trying to fix it. And it's not a Republican thing or a Democrat thing. Every single president has tried to get their hands on an industry because there's a lot of money associated with it. And with every new regulation that they impose, they escalate the cost, and that impacts us as American citizens.
See, so where I would differ is I would say is that I think government does have a responsibility. We do need to ensure that companies that come in, private sector, yeah, we can do partnership, we can do all sorts of things. Well, we do have a responsibility as government to ensure that there is, as best we can, to design a system that's going to work for a community. So like in a public health department, let me give an example. I'm not as interested or concerned about hospital X or hospital Y getting the credit of whatever happens in their, their proprietary and their fights and their arguments or their challenges of their system is better, their advertising is better, their health. I'm interested in the population. It doesn't matter if someone goes here or someone goes here. I'm interested in the entire, in the case of Harris County, 4.5 million people, that I want to make sure the entire population is healthier. So that's a government role that is in essence, as you can imagine, it becomes an arbiter, if you will, that there's a trust and a currency of trust that comes in there that private sector may or may not have, and that's something that we need to at least acknowledge.
Well, let me ask you this. I was just thinking about this. We have the state government has put together a website for electricity competition that you can get on access, and you can compare apples and apples and figure out what the best deal is for you. Okay, so we don't have any website like that for medical accessing the system, do we? To make it easy for people. What's your income? What do you qualify for? You could go to the Harris Clinic. You go to the City of Houston Clinic. You can do this or do that. I don't think we have a central information source. So maybe we need to do that.
Well, there are a lot of states that have actually looked at this and trying to figure out ways that they can actually make it more transparent to the consumer. But David, what we're talking about is that's it's a challenge.
Not only transparency, but just as you said, to offer more than just, because some people only believe that if they're too young for Medicare, that the only option they have available to them is the ACA. That's just simply not the case. And so it would be good for everyone to know what the options are. I agree. I think that would be a wonderful tool to have at the state, county, and city level.
Can I ask a question? And in the sake of time, I'll make it brief, and hopefully your answer should be yes or no. Are we less healthier as a country because we are a capitalist country?
I would say no to that. I don't think that at all.
I would say we are less healthy. I'm not sure if it's because we're so I agree with the first part. We're less healthy.
I agree with
I'm
that.
not sure I agree with the premise of because we're a capitalist country.
Okay, follow up.
Okay, well, I have a question. Okay. What happens in socialist countries where everybody's supposedly treated equal, though some are more equal than others, David?
Gary, I didn't like
what happens in those socialists? As I said before, rationing is an inevitability in that kind of system. And we should treat people with dignity and exceptionalism. Those are the things that are American ideals. And we should be able to have health care that's affordable. You talked about TVs and iPhones. You see, because they're not as regulated by the federal government, you see competition and you see choice and you see the decrease in the cost. That's what would happen with health care. And we're seeing that when they don't operate within the typical types of constructs.
By the way, I do have to ask you about one of my pet peeves. Prescription drug advertising on television. What is the purpose of advertising a prescription drug on television to people who don't necessarily have the problem? I'm missing something. And by the way, they write it off on their taxes.
I don't understand why they're the worst commercials in the world. Because at the end, they give you like 1 million side effects. You're like, I don't want that.
No. But they tell you that the side effects or something. No, they stress the side effects that you may want. No, that you may want actually.
And you want to hear something that'll blow your mind? Here recently in the Senate Finance Committee, they admitted to the fact that they spend more on advertising than they do on research and development.
That's ridiculous.
That's horrible.
It is insane. And the other thing I wanted to mention, other ways of delivering medical care. Like, for example, in your clinics, do you use nurse practitioners?
Sure.
Do they see patients?
Sure.
Without under a doctor's supervision?
Well, I mean, it's standing delegation orders, but yeah.
Right, okay. And one of the things I was reading in the Texas Public Policy Foundation guide for the legislature, they talked about dental assistant practitioners being needed because there's a great need for dental care in the state, and lots of folks aren't getting services from underserved communities. So is that something we should be doing?
This is So I do think that we can also look at what's happening both across the country, but also globally. There are models, there are examples of ways that what happens in health delivery in other parts of the world can really be applied to models of excellence that we could apply here locally. I think that's one piece. But the last thing I would say is that we are never going to get out of this conundrum about healthcare delivery and healthcare, the cost of healthcare, affordability, until we start to really get into understanding health is beyond health care.
Great.
That sounds good. Okay, surprise billing. There's a bill coming through the legislature about that.
Yes, no,
You got
Senator
15
Hancock.
seconds. What does
Easy.
it do?
If you've been to the emergency room and you thought you were in an in-network facility and you thought this is under my insurance, but then you get 7 bills and 4 of them are from out-of-network providers, that's a surprise bill. You're surprised. That's not something you expected. There is a bill going through the Senate right now, and there's a companion in the House that will protect patients and limit them to the benefits of their plan if they went to an in-network
The
facility.
model word there is transparency. Well, thank you, David.
Transparency up front. That's
David
right.
Balat, thank you so much for coming.
Thank you.
Dr. Shaw, appreciate the work you do. Get the information on Post Dallas. Always a pleasure. We'll be back next week with another interesting show.